Bismillahirrahmanirrahim. Assalamu alaikum. So today we have in continuation of previous lecture, that is acute tonsillitis, and now we are reached on chronic tonsillitis. You know that it is a complication of acute tonsillitis. And when you remember previous lectures, then this one is that three things is converted acute into chronicity. The first one is the improper treatment. And the second one is the high virulence of the organism. And third one is the low resistance of the body mucosa. These things convert acute into chronicity. Now we have a first complication of acute tonsillitis, that is a chronic tonsillitis. Chronic tonsillitis. This is a very beautiful picture in front of you. That is a chronic tonsillitis. When we label the chronic tonsillitis, when there are 3 to 4 consecutive attacks every 3 months, and in a year, that we label as it's a chronic tonsillitis. Chronic tonsillitis. You know this picture, just like when we are going to a types, that may be a parenchymatous tonsillitis, and you are easily watch that both these tonsils are meet to each other. That is, we are also give a name of a kissing tonsil. We give a kissing tonsil. And you know it very well. This is a huge hypertrophy enlargement of these tonsils. Okay. Now the etiology causes, you must know that we are already in front of page, that is an inadequate and proper treatment, that is an acute phase. Causes in a tonsil. Yes, you know. Causes in upper respiratory tract infection, when we are caused that this is a relative cause. We cause is a relative, neighbor cause. That is a rhinitis, sinusitis, pharyngitis, nasal obstruction disease. Nasal obstruction disease. These things cause the tonsillitis. Now, causes in oral cavity, you know, poor oral dental hygienic conditions. Poor orodental hygienic conditions. And the causes outside the body, taking of infected food, too cold or sore thing, less resistance of a palatine due to malnutrition, cold or wet climate, bad sanitation, overcrowding, and ill ventilations. You know, these are the relatively cause inside, close to the tonsil, outside causes. These things cause help in to a chronicity. Pathology. The pathology is that you know, there is also type in acute tonsillitis. Here is the same thing that is come into a chronic tonsillitis that cause a macroscopic picture. This is not a micro, this is a macroscopic appearance, in which number one is the chronic lunar tonsillitis. The name is a follicular tonsillitis. You know very well, when there is a beads inside the tonsils and they are come over the tonsil, it's look like a follicles. That is a name as a follicular tonsillitis. Okay, the name is a follicular tonsillitis. Now, second one is the chronic hypertrophic or parenchymatous tonsillitis. The picture which we have start first on lecture, and that is a picture which is first one that show enlarged parenchymatous hypertrophic tonsillitis or kissing tonsillitis. You know that this is a second one here. The type is a chronic hypertrophic or parenchymatous tonsillitis. Now, third one, you know that when there is a shrinkage, that is called chronic fibroid or atrophic tonsillitis. Chronic fibroid or atrophic tonsillitis. This is a very painful condition of a patient when you look at throat side that there is no enlargement of the tonsil, but it is very just like fibroid or atrophic stage, and the pain is a severe condition in these patients. Okay. Now, below this, there is a microscopic appearance. Show lymphoid tissue, hyperplasia, or fibrous tissue. Shows lymphoid tissue, hyperplasia, or fibrous tissue. Now the symptoms. What happened? What happened with patient when the disease? His patient is going to when chronic tonsillitis. Number one, there is a repeated attack of sore throat. If you remember that my first indication is that if there is a 3 to 4 attack within 3 months, and in a year 4 time, that is called chronic tonsillitis. So here the first local call is a repeated attack of a sore throat. And now second thing is difficulty in solving during acute phase due to mechanical obstruction in children. You know that when there is an enlarged and there is a parenchymatous tonsil, kissing tonsil, the space is full with tonsil, so they have a difficulty in solving. That is called mechanical obstruction. Now, third one is the bad taste and foul breathing because of chronic inflammation. Bad taste and foul smelling because of chronic inflammation. Constant desire to clean throat due to enormous enlargement of tonsil. That's feel that there is a something in throat, foreign body like something in throat. That patient having a constant desire to clear his throat. So this is here constant desire to clean throat due to enormous enlargement of the tonsil. Journal cause during the take of patient look ill with low-grade fever. Adult may complain of ache in the body. Focal otitis media. If this is not treated, they may cause otitis media, sinusitis, bronchitis, rheumatic heart disease, acute pyelonephritis, nephritis, repeated eye infection, joint infections. These are going towards the side, neighbor side, downside. Now the invading Streptococcus beta hemolyticus group A produce allergens or toxin which are responsible for heart disease. The abnormal sound or murmur in heart comes from the involvement of the mitral wall and less often from other walls like aortic wall. Mitral wall is the most commonly affected. It gets infected and scarred. The scar tissue build up over the years into a stenosis or closing off. That is a pathology, especially the bacteria which is involved here. tonsillitis, that is a Streptococcus beta hemolyticus group. Now you see a sign, it's a very good picture. You know that with the help of a tongue depressor, we depress the tongue and the side is a huge congestion, red. There's a secretion there. That is a sign here, size of a tonsil, linear congestion on the anterior pillar of tonsillitis. Tonsils, you know that there is a congestion. Crepes, you know that there is a multiple crepes in the tonsils, and then there is a big crepe at the upper pole, that is a crypta magna. On applying pressure, tonsillar cyst, sometimes we have examined when with the help of tongue depressor, we know that if you're going to a right side, you know that there is a tonsillar cyst. This is a material, you just come to upward side, and when we are with the help of tongue depressor, press it. So we are creamy material white at the right side. So figure that show a tonsillar cyst. Regional lymph nodes, yes, this is a very important here. This is a sign. When there is only jugulo-digastric lymph nodes that is enlarged and palpable, that is also a sign of a chronic tonsillitis. Diagnosis, that is a history examination. DD, that is a chronic pharyngitis. Sometimes it is related to a just mixed picture with the chronic pharyngitis. Treatment. Conservative treatment, general measure, improve the general health of patient, avoid cold and sore things. Any source of infection in the neighborhood should be eradicated. You know that eradicate neighborhood means if there is a sinusitis, you correct sinusitis. If there is a DNS, you correct DNS. If there is a pharyngitis, you treat the pharyngitis. If there is allergic rhinitis, then you treat the allergic rhinitis. Otherwise, patient have a problem of these things continue. So you have now avoid cold things, sore things that should be avoided at a time. Local measure, maintain oro-dental hygienic condition. You must pay attention to a oro-dental hygienic condition. It is a one of important cause there of tonsillitis. So locally we have a throat pants, and local and systemic antibiotics is there. But you know that very important thing is that acute things when change into chronicity, when patient is going into chronicity, the thing is that you take the measure, the thing which is cause that tonsillitis repeatedly take, you should be stopped. Otherwise, you know that there is a treatment of chronic tonsillitis is a surgical treatment. Surgery is the treatment, because if you have a repeated attack, if repeatedly time these things with the patient, so you go on surgical sides. So in chronic tonsillitis, treatment of choice is a surgery. Now, this is an indication. This is an indication that where we do when we come on surgery. When we come on surgery, okay. When we remove the tonsils, these are our friends. So it is present by birth till death with us. So at what time we separate it? So number one, you know that then when there is a repeated attack of sore throat, and every 3 months we have an attack of this tonsillitis, it's get a problem to our body repeatedly time, then this is a first indication that we take measure that we do going to side the surgery. Number second is the quinsy. When there is a attack of quinsy, this is a complication of acute tonsillitis. Number third is the pharyngeal diphtheria. Number fourth, mechanical obstruction. Then unilateral enlargement of the tonsillitis, especially in old people. Early malignancy of a tonsillitis as an approach to ninth nerve stellate process. Tonsillolith, when there is a stone in the tonsil, you know, a stone in the tonsil, we do the tonsillectomy. foreign body pierce into the tonsil. When foreign body pierce the tonsil, that also it is an indication of removing that tonsillitis. Before repair of cleft palate, before repair of, and you have a child of cleft lip, cleft palate, you know that there is a inside throat oral cavity. When there is a cut, we call is a cleft palate. So before repair, we do a tonsillectomy operation. Number B cause, when there is a problem of this chronic suppurative otitis media C due to chronic tonsillitis. When you know that there is no any treatment, repeatedly we have treatment of a chronic suppurative otitis media, but patient have not any improvement, and along with that there is a chronic tonsillitis. So in such cases we are going to do a tonsillectomy surgery. Okay. Tuberculosis cervical leaf adenopathy C due to chronic tonsillitis. If there is a both side leaf channels, they are involved and the cause is behind is a chronic tonsillitis. So we are going to operate these tonsils. Non-specific cervical adenitis. If there is no anything is found and you know that treatment is given, but there is a leaf adenopathy, at that time, we have also do a tonsillectomy. Sinusitis C due to tonsillitis. If it's a repeated attack of sinusitis and it is subside again, there isn't happening, and you know that the patient is having also chronic tonsillitis, so we have going to do tonsillectomy. Bronchitis C to tonsillitis. If there is a repeatedly chest infection, repeatedly, and it is not be a control, and we are also examining that patient have a chronic tonsillitis, then we go to surgery side. We go surgery. That is C cause journal. These are the, you know, all these things are the complication of a chronic tonsillitis. That is a rheumatic fever, rheumatic arthritis, nephritis, subacute bacterial endocarditis, pyrexia of unknown origin, PUO, child not gaining weight, child is not gaining weight. These are all measures which are in front of us. This is a cause where we remove the tonsil, where we take the step of surgery, where we do tonsillectomy. These are a whole huge list. You must be minded. So in the cases, we are going to tonsillectomy. So these are all indications. You keep in mind, please, when examiner asks you what are indication of a chronic tonsillitis operation. So you put this list that these are the indication of a tonsillectomy surgery. Now contraindication. Which condition is there when we are not doing a tonsillectomy operation? Okay, that word is mind behind is a contraindications. Contraindications. The A step is a physiological state. Here, the number one is that book is written that under 4 years of age, some reckon is that 3.5 years of age, and there is a over 60 year of age. That is a physiological contraindication that we are not doing a tonsillectomy of these ages. And physiological condition during menses, we are not going to a surgery. During pregnancy, we are not going to a surgery. In a very hot weather, we are not going to a surgery. In singers, when there is a singer and that have a chronic tonsillitis, so you must say, because when we are doing a tonsillectomy, that the sound is little bit changed, the voice is little bit affected, maybe little bit affected, so that we must be put in front of us, that singer, that maybe little bit you have a little bit change of voice. Pathology. That is a number one, blood dyskaryosis. Blood dyskaryosis means blood disease, that all blood disease, for example, hemophilia, that is all other that have a disturbance of the clotting factors or there is a bleeding, that all come in blood dyskaryosis. Number one, uncontrolled hypertension. Uncontrolled. If there is a control, then we do tonsillectomy very well. Uncontrolled pulmonary tuberculosis, then pulmonary tuberculosis is treated. That is, the active period is a 3 months. If this is a well controlled, then we do the tonsillectomy. But this is come in contraindication: uncontrolled hypertension, uncontrolled pulmonary tuberculosis, uncontrolled diabetic mellitus, acute in ENT infections. You know, it's a very easy to understand acute ENT infections. You know that when there is acute rhinitis, acute sinusitis, acute tonsillitis, okay, acute otitis media, these are all causes of acute upper respiratory tract infections. These are all come into acute ENT infections. So at that condition, we have a contraindication of a surgery. Before first we correct these things, then we are going towards the surgery. That is behind this acute ENT infection, there is allergic rhinitis. Allergic rhinitis. Now here, this is an infectious fever, toxic state, jaundice, submucous fibrosis during polio epidemics. These are all here is a contraindications. Submucous fibrosis, now day by day there is an increase because all we have in a pocket there is a chalia, supari, that is a Rajnikal, Ratnikal, Safina, each and everything, and we have chewing all the time to our throat. These are the chemicals which produce this disease that is called a submucous fibrosis. That is a condition where patient is unable to open the mouth. When patients are unable to open the mouth, so that have a very difficult to anesthesia and the surgeon that how we progress this surgery. So this is a very dangerous disease nowadays. It is a pre-malignous condition also, and that could be changed into malignancy, submucous fibrosis. Now investigation. You know that each and every disease have an investigations, because these the things which are very helpful for surgery, very help to reach the diagnosis. So that is a very important for each and every disease, that name as an investigation. You see that along all routine investigation, that is a blood CP, bleeding time, clotting time, platelet count, urine DR, X-ray. This is a mandatory. This is a mandatory. And before we are going to a surgery, we have a must that doing that any blood sugar is there. So okay, blood sugar we have find it. So these chest status, urine, any infection, any blood CP report that showing that a hemoglobin or there is acute infection now, and platelet, whether we have platelet aggregation is there. So these all things must be widely be watched when patients are going into a surgery site. And then there is a throat swab for culture sensitivity. So it's also an important investigation that you have take a throat swab for culture sensitivity. It is easy to put on patient on that drug which is sensitive at that time, which report show you. Otherwise, before report, we have choose a broad spectrum antibiotic, which cover the gram positive and the gram negative bacteria. Method of tonsillectomy. So this is a very important for examiner. Mostly ask you that you have examined the tonsillectomy. So how many method you do tonsillectomy? Which is a current method of tonsillectomy. In your OT, which method is or surgeon should be applied. So it's a very important method of tonsillectomy. You know that you must be know a tonsil of instrument of tonsillectomy. This is important because it is a key topic. In throat, there is a very important topic for examination point of view, theory point of view, viva point of view, because it is a key topic. Method of tonsillectomy. So number one is the dissecting method. The method which is in front of you, and first one, dissecting method. This method is adopted we in our OT. So all the tonsillectomy we have doing with a dissecting method here. Okay. And second one is the gluten method. This is the old method. Cryosurgery method. This is the old method. Now this one is the diathermy method. Now we have changed dissecting method over the diathermy method. Diathermy method. But in diathermy method, that the thing is that the patient have post-operative pain. In dissecting method, if we respect the tissue very well, so that method is a not painful method, but diathermy method is a painful method. Okay, but day by day, it is a very common diathermy method. So if we are going to preference to dissecting method, that is a diathermy method. And the last one is here is a laser surgery method. So laser is not available in our department here, but there is a method. Carbon dioxide laser method use. Why we use carbon dioxide? Because it have two properties, that is cut and coagulation. Cut and coagulation. That's why we preference laser surgery method in ENT and carbon dioxide lasers. That's having two property, cut and coagulation. Now you know, just idea I give you, because this is the idea of our OT. So preparation of patient, anesthesia steps. You know that it's a picture in front of you, and you know that there is an opening of mouth, dissection of tonsil, squaring hemostasis. This is a method. First thing is that is a method of tonsillectomy is a position of tonsillectomy is rose position. Rose position. You know that table when there is an instrument that is a Bowel Davis mouth gauge. This patient is extend neck here. This is a rose position. This is one is a rose position, and in that position, all the Meyer is taken and surgeon is ready for operating the tonsil. When you operate the tonsil open the mouth with the help of dissection or with the help of diathermy, you have removed the tonsil. The main important is securing the hemostasis. The main thing, the main importance in tonsil is a hemostasis. Hemostasis is must when you are knowing a tonsillectomy. If you are knowing only dissection and not securing hemostasis, it gives a problem. Now you look a very good picture of a bookish picture, you know, before and after. Before you see the area just uvula in the center and the gap is there. In that gap, there is a mass-like picture that is a tonsils. And here in afterward, that you know that mass is removed here, that is a tonsil, and just like in a spot here, just like the area is looking that it is a dissect. It is the dissect. Very good picture. Very good. Advantage of dissection method. Yes, there is a very important. The tonsil are dissected out completely. In which say that when you are going to dissect, that there is a less chances of that you remain the part behind of a tonsil. So you dissect out completely. No other structure like base of tongue or uvula are injured. When you are going to dissect and hold it and it separately out from the capsule, so it's very advantage is that you should not damage tongue, uvula or other injury there. Post-operative care. Post-operative care. In operation theater care. Care of breathing. Tongue might fall backward. Okay. So you must watch patient here. The tongue might fall backward. If patient are not fully awake, the tongue may fall and patient may be dying. Clotted blood may be inhaled, in which you are sure that there is no blood inside. You suck very well. Otherwise, when we take out the tube, the patient may be inhaled the blood. Swab might be left in and inhaled. You say that when we are doing a tonsillectomy, multiple swabs are put side by side and then we remove. Sometime if you have a nut counted swab and it is left there, that there may be inhale. Patient might vomit and inhale it. Okay, patient might be vomit or inhale. Patient maybe if there is vomiting, if it is not in a proper way, the vomit should be inhaled. So it give a trouble to a patient. Second, observation for bleeding. Sedation to avoid struggling by patient. In the ward, NPU for 4 to 6 hours, then ice cold water, milk, ice cream, or alone. So before NPU 6 months post-operative, when patient is fully awake, then you use the cold things. Cold water, milk, ice cream should be allowed. Antibiotics, analgesics, antiseptic gargles. Okay, and avoidance. Some says that now I have an operated and taking smoke, alcohol, hot, and a solid thing. These should be avoided because these things should be create a trauma, and then there is a bleeding is started. That is a very alarming thing in tonsillectomy. Then there is a complication. This is also your important topic because mostly examiner ask you what is the operative complication of a tonsillectomy. So your answer is there, sir. There is a complication on the operation table due to anesthesia. That is a cardiac arrest, respiratory failure, lungs collapse, injury to nasal mucosa, lips, teeth, gums, tongue, pillars, and the posterior pharyngeal wall. This is on the table, cardiac time, when there is a tube is paused. This is due to on table at anesthesia complex. And due to surgery, injury to nasal mucosa, lips, teeth, tongue, postpharyngeal wall, dislocation of the temporomandibular joint, primary hemorrhage. This is due to surgery because when are put the Bowel Davis mouth gauge and they have enough to apply the force, you may be trauma easily these parts. In the ward, respiratory obstruction causing asphyxia, reactionary self-separating secondary hemorrhage, infection of the tonsil fossa, adenitis, referred otitis media. In the ward, they may be there, and the late tonsillar remnant, if remain behind, that gave a problem. If too much stitch are applied, too much fibrosis, stiffness of palate, change of voice, regurgitation of fluid. Because when you are doing this problem and there is edema of the soft palate and there is a edema that make a fibrosis, so it is not moved properly in a way that in a normal soft palate, when patient take the thing, these are come from the nose sides, regurgitation of fluids. Persistent pain for longer duration. Persistent pain for longer duration. Yes, here the mostly the important thing is a complication, that is a primary, reactionary, and the secondary. Mostly examiner are only give a bleeding complication. So that is important in that primary complication is on a table, reactionary complication in a ward within 24 hours, and secondary complication after 5 days to 14 days. And that is the most dangerous complication is a secondary complication. It is due to infection. It is due to infections. So that's why it is dangerous complication. So when we are doing chronic tonsillectomy operations, we take fully all the measures which we have discussed and apply over the patient, and that how we secure our patient. All these things are present in the lectures. Okay, so you have going to your books and you see these topics one by one. So it's very easy to understand, and you must be tick that it is a key topics. So it is a key topics. So thank you. Now I come to our last things. So now you have a poetry. कितना मुश्किल है अजियत ये गवारा करना, कितना मुश्किल है अजियत ये गवारा करना, दिल से उतरे हुए लोगों में गुजारा करना। जिंदगी हम पे ये आसान भी हो सकती थी, सीख लेते जो किसी दर्द का चारा करना। कहाँ जाते हो अभी साथ गुजारो कुछ दिन, हम पे मुश्किल कोई आई तो किनारा करना। कितना मुश्किल है जलाना किसी रास्ते में चिराग, कितना आसान है हवाओं को इशारा करना। जिंदगी हम तो चलो मान के सह भी गए, ऐसा बर्ताव किसी से न दोबारा करना। थैंक यू सर। आइए।